Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, welcome to this week's episode of the Healing Pain Podcast. Today we're discussing ways to increase bone density with Dr. Pam Tutten. Pam is a doctor of occupational therapy and a certified hand therapist who practices at Benchmark Physical Therapy in Ellijay, Georgia. Pam became interested in osteoporosis because of the number of women with preventable wrist fractures that she was seeing in her practice. She later on developed a group program that addresses the importance of diet and exercise to improve bone health and provides options to medications for patients who are looking to treat osteoporosis as well as osteopenia. On today's episode, you'll learn what is osteopenia and osteoporosis and how it gets diagnosed, alternatives to medication for those diagnosed with osteopenia and osteoporosis, how changes to one's diet can improve bone health, how exercise and physical activity can improve bone health, and why this is important to improve the quality of life for people living with pain. Pam has also provided you with a free gift to accompany this week's podcast. It includes 3 different PDF handouts about the treatment of osteoporosis as well as osteopenia. The first one is called Food for Thought, How Nutrition Has an Effect on the Health of Your Bones. The second is a full exercise program for osteoporosis. And the third are helpful links for patients with both osteoporosis as well as osteopenia. To download this week's free gift, all you have to do is text the word 180-DOWNLOAD to the number 44222. That's 180-DOWNLOAD to the number 44222. Or you can open up a new browser on your computer and type in the URL www.integrativepainscienceinstitute.com/180-download. I'll say that one more time. That's integrativepainscienceinstitute.com/180-download. I highly recommend you download those 3 PDFs that accompany today's episode. Okay, let's begin with the wonderful Dr. Pam Tutten. Hey there, Pam. Thanks for joining me this week on the Healing Pain Podcast.
Oh, thank you for having me, Joe. I really appreciate being here.
I'm so excited to talk to an occupational therapist. As we mentioned before, I have to be a little bit better and get more occupational therapists like yourself on the podcast to talk about pain and the various conditions and diagnoses that all of you treat, because you're an integral part of pain care and, of course, multidisciplinary treatment of pain. And many OTs like yourself work in private practice that have so much to offer to people who are looking for health and other types of treatment for their conditions. One of your specialties is osteoporosis or osteopenia. We'll talk about both of those today. Tell me how you became interested in that topic and treating people with that.
Well, there's a few different reasons that I became interested. One of them is that my mom has osteoporosis. Another one is that I am a certified hand therapist. So I treat a lot of hand injuries, specifically wrist fractures. And a lot of times those fractures might have been prevented if somebody had known they had osteopenia or osteoporosis and had treated it through the ways that we're going to discuss on this podcast. The other reason is that when I was studying for my doctorate in occupational therapy, one of my projects I selected was osteoporosis, osteopenia, and it opened my eyes to what can be done besides medications. So many of the medications have so many side effects that I was happy to know that there's a lot of diet and exercise options that actually show great results in improving bone density.
Excellent. Of course, we're going to talk about all those today.
Yes.
And maybe even some of the things that you found in your doctoral work. So tell me, when you reflect back on your practice and these patients who are coming in with wrist fractures, is there a typical type of patient or person who may be predisposed to developing osteoporosis or osteopenia?
Well, as you know, because I've read your book, that we have a very sedentary population in the United States. We have a sedentary population who follows the standard American diet, which is not very healthy. They sit on the couch watching TV, and so obviously their bone density is going to be lower. I would say at least 80% of the patients that I see in my practice in Georgia are obese, or maybe not overweight. So their BMI is going to be over 25. I would say at least 50% are over 30. So that's going to contribute to the risk of fractures. Their diet, lack of exercise, all that we know contributes to bone density.
And what type of fractures are you seeing? So obviously wrist fractures. You're also a certified hand therapist in addition to being a doctor of OT. So this is well within your specialty.
Yes.
What kind of different fractures happen with people with falls?
Typically the distal radius fracture, a lot of times it could be both bones. A lot of times there's a little tip of the ulnar styloid is going to be fractured as well. But typical, it's a fall on an outstretched hand. Distal radius fractures, complications with ligaments sometimes, but it's, I would say, mostly the distal radius fracture that is the prime symptom of osteoporosis and osteopenia.
And so you mentioned falls. People tend to think of people fall when they're very elderly or very old. Would you say that's true, or that's a myth with regard to the patients you're seeing?
No, I think that as we age, our balance maybe deteriorates a little bit, and I think you have to be a little more careful. But I do see, I do see all ages of patient in my practice. But I would say it's the over 60 population that I'm most concerned with in terms of bone density. And typically that's like being careless, being in a hurry, tripping over the curb in the parking lot, slipping in the shower, those are the typical injuries that I'll find, or trying to stand on a ladder to change a light bulb, or stand on a stool or a chair. I've had patients climb on a counter. You're 60 plus years old, you really shouldn't be climbing on a counter. So, in this rural area that I practice, I have like women climbing on roofs, cleaning gutters. So those are probably, they might have fractured anyway, honestly, but it didn't help that they had osteopenia.
Tell us about the difference between osteoporosis and osteopenia.
Well, it's basically a continuum. It's a continuum, but it doesn't necessarily have to progress past osteopenia. So a patient or a person who has a bone density exam, which is pretty much the gold standard for diagnosing bone density issues, is going to get a T-score. It's called a T-score. That T-score, if it's within normal range, so if you think of and I'll try to show it with my hands, the standard curve. So we're talking about the normal population is at the top. This is like the average number on the score. That within one standard deviation is going to be -1 to +1. So the peak of that is a 30-year-old female, her perfect bone density. You're going to say perfect bone density. So that's the 0, say. Anything between 0 and -1 is going to be considered normal. And then you get -1 over in that like small part of that curve, -1 and to -2, -2.5. Then we're talking about osteopenia and osteoporosis. Now the osteopenia is -1 to -2, 2.5. Then it's osteoporosis. What we're finding through lots of research is that it doesn't necessarily have to progress, and we can reverse it with diet and exercise. So, but that's why I hate to say it's a continuum, because people think, oh, just because I have osteopenia, it's going to become osteoporosis, and that is not necessarily true, and that it can be reversed. One thing I do want to mention too is that I believe we have really underdiagnosed this in the United States, and that most of the research is being done in Europe, and it's really, they really aggressively treat this. So we're worried, I know, in our society about fall prevention, fracture prevention, but the root of it a lot of times is bone density. And one other piece of important information when you're talking about this is that one of the big contributors to poor bone density is the antacids, Nexium, Prolia, the proton pump inhibitors that almost everybody's on. Everybody seems to have heartburn, whether it's due to obesity, poor diet, lack of exercise, whatever reason, they all are on this medication, which weakens your bone density. So my guess is that not only are we going to see more people with this diagnosis, but more men, because it's typically a women's disease, like women of slight build, Asian build, those are more common, but we're probably going to see more men. And I will say that my husband is one of those men who's had heartburn on it all his life. not because he's been unfit actually, but because of some kind of hiatal hernia that he had. And so for years he's been on Nexium, and he suffered some knee pain that we discovered was osteonecrosis, which with further testing, we found out he had osteopenia, probably from being on these medications for years. So we have switched dramatically his diet. We've put him on my program, which we'll discuss more. And hopefully, I'm praying that his next bone density will be more normal. But I think men need to be warned too, that this is a risk. And hopefully we will address it more in our society.
So many good take home there for people that they can rewind this and listen to exactly what you just said. Because in that little, maybe that was 3 minutes long, so many good take homes for people. So if I can help you summarize a little bit. So a T-score of less than a 2 puts you in that osteopenia range, not osteoporosis, osteopenia. And in that range, you have the ability to either halt the progression or potentially even reverse it.
Yes.
With lifestyle-related treatment, which we'll talk about in a while. Which is important because people think that once I have this, that's it. My bone's just going to continue to deteriorate, and I have to be on medication. There's nothing else to do. And you're saying that the research shows that's not true.
Not true. Not true. All the current research. And another piece of important data, I think, especially for women, is that, for years past, hormone therapy was a big thing. Everybody was on hormone therapy. They go through menopause, they go on hormone therapy. Then all of a sudden, the American Heart Association came out and said, "Oh no hormone therapy. It's a risk to your cardiovascular health, blah blah blah." And now in 2013, the International Osteoporosis Association came out and said, "No, it's very important to consider hormone therapy because of your bones, and that the risk of bone disease, osteoporosis or osteopenia, bone density problems, is higher than the risk of cardiovascular problems." So they're saying, no, you really should consider hormone therapy. And honestly, I kind of think that's a safer. So if you want to take something like besides diet and exercise, and you feel like you're doing something, talk to your doctor about hormone therapy. Obviously, I can't prescribe that. I'm not a medical doctor, but talk to your doctor about that and remind them that the 2013 statement that came out, you can look it up for yourself on the International Association of Osteoporosis. They said they support it based on research.
Excellent. And then you also mentioned proton pump inhibitors, which on this podcast, we talk a lot about nutrition and diet and the role of the gut and how it affects the rest of your body.
Very important.
So can you explain to people why proton pump inhibitors can predispose someone to osteopenia? Because there's really good data that those with fibromyalgia, upwards of 70 to 90% in clinical studies, have IBS. And people are taking things like proton pump inhibitors for their gastritis, their heartburn, their IBS, and things like that. And they're not making the connection between what does treating my heartburn have to do with my bone health?
Yeah. Oh, well, I wish I was a chemist and could explain this better because I'm terrible at physiology. Maybe you might even know more than I do about that. I do know that it depletes the calcium in the gut. And like I said, you probably know a little bit more about it. And if I were listening to this podcast, I would research it and talk to my doctor about it specifically. But yeah, I should know more. And I've read about it, but for some reason it doesn't sink in my brain too much.
Yeah, what you said is 100% right as far as calcium in the gut. So proton pump inhibitors decrease hydrochloric acid in the stomach. You need that hydrochloric acid to break down protein in your digestive tract. If you're not breaking down protein, one, your body can't absorb and utilize the amino acids that it needs to build bones because your bones use the amino acid. Also, as you're cleaving proteins and you're breaking down other types of macronutrients, exactly what you said, the calcium is not liberated and the calcium is not allowed to pass through the gut and get absorbed by the rest of the body. So you have lots of different factors with regard to proton pump inhibitors. The other thing about those medications is they can also cause nutrient depletions, meaning even if you're taking in a certain amount of nutrients, things like magnesium, which we'll talk about in a little while, doesn't get properly absorbed either. So it's such an important point I wanted to go back to, and I think bring up the point about men as well.
Yes.
Even kids, I even see kids take things like this, and we know that bone health starts at a really young age, right?
Right. Yes, it does. I mean, basically, we're building our bones up until we're 30, and then after 30, it's all downhill. So you better start paying attention to keeping your bone density nice and strong.
Yeah.
Um, but you do bring up nutrients too, and I don't know if that's part of our thing, but with calcium, there's been a lot of discussion in the community about osteoporosis, osteopenia. Do I need to supplement calcium? Do I get enough in my food? And I get that question a lot. And basically, I think the research is really pointing to the importance of vitamin D over calcium, especially for bone health. So I am usually a stickler about having my patients get a blood level for their vitamin D. And the standard has changed, and the labs haven't kept up with it. So what they're saying is 30, a number of 30 or over is the right number, but it's actually not. It really needs to be 50. So the new standard is 50. And a lot of my doctors really want their patients at 60. Some of the rheumatologists are recommending 60 because we're finding vitamin D has a whole lot more than just about bones. It also is about autoimmune. It helps your immune system. It helps prevent autoimmune disorders. It helps with even dementia, they're finding. So preventing dementia, not causing it, of course, but so vitamin D is what I stress with my patients, and I also recommend, based on the data that I've read, that people take for a maintenance dose of 2,000 IU a day. And I don't think we get enough from our food. I think it's kind of difficult to get enough from your food. So I feel like almost everybody needs vitamin D supplementation. And ironically, especially people with darker skin, with the melanin, and again, my physiology is not as great, but melanin has a role in the way vitamin D is absorbed. So I wonder if that's why we see more immune deficient, African American versus white skinned people. But osteoporosis, osteopenia, more white skinned, small Asian, but vitamin D deficiencies can be more prevalent in the darker skin community. So anyway, for what it's worth, I'm a big fan of vitamin D. Less of a fan of supplemental calcium. I feel like it's so important to take calcium in your food sources like yogurt, milk, dairy, cheeses. I think that's really super important. But if you can't tolerate it, if you're lactose intolerant, then you might need to supplement a little bit.
Yeah, you can also find some vitamin D in some cold water fish. It's in the meat as well as the skin of the fish. So
eggs. I'm like a huge proponent of eggs. And if you like liver, it's really good.
And liver's very good for you, actually. People can incorporate that in. And yeah. I appreciate you mentioning and keeping us up to date on one, make sure you have your vitamin D tested. It's amazing how many people do not have
it. And it fluctuates.
And it fluctuates throughout the year, especially if you're in a northern climate, or you mentioned if you have darker skin, it's something you have to stay on top of. And you mentioned calcium. Talk to us about some of the foods and things we should stay away from that can adversely affect your bone health, osteoporosis, and osteopenia.
Well, obviously smoking, alcohol, the typical things. There's mixed actually information, I think, on carbonated drinks like sodas. People will hear that rumor. I've actually haven't found anything solid that I can hang my hat on and say, oh yeah, this is super bad for you. But I mostly, too much caffeine. Sometimes there's an argument for too little or too much protein. I've seen some of that in the literature, and sodium. So, some of the things that just aren't good for you anyway. So too much caffeine. Although, interestingly, and you probably know this, that the American Heart came out and said you can have up to 8 cups of coffee a day and it won't affect your cardiovascular system. So good for Starbucks.
Good for Starbucks. I think that's extremely high for people.
I think so too. But I thought that was like, oh my gosh, really?
Yeah. Well, I guess it's okay. They claim it's okay for your cardiovascular system. I'd like to see more research on that, so to speak. But it definitely affects your cortisol levels.
Yeah.
Which can have an effect on not only your chronic pain, but also your bone density.
Right.
And we know that because people who are on corticosteroid medications, those are one of the medications that affect people's bone density. So
that's true.
As you play with cortisol, you have to make sure as you mentioned before, you have to make sure you're under that curve.
Right.
If you're in the outskirts, it can be a problem and a challenge for you.
Right. There's a couple of other medications, like any kind of the rheumatoid medications, methotrexate. and excessive thyroid medication. I knew there was one more I was forgetting. I needed to look down at my notes.
All important. I mean, thyroid disease,
Mm-hmm.
hypothyroidism is the number one autoimmune disease in the country. And as you mentioned, any of the disease-modifying anti-rheumatic drugs all have that side effect of
Right.
poor bone density, which people with chronic pain, a lot of them are on some type of DMARD, disease-modifying anti-rheumatic drugs. So very
Right.
important. So if you're on those medications, it's always make sure you, as Pam mentioned before, make sure you get your levels checked. Make sure you're following some of the lifestyle recommendations that she's outlining in today's episode. And ask your doctor, what's the lowest dose I can be on that's beneficial? I often find
Right.
that sometimes people are placed on very large doses of medication that they don't need instead of starting out at the smallest amount and seeing what the change is for people.
One important thing that I didn't mention is the difference between vitamin D2 and D3. There's actually some good studies on that. And interestingly, every time I have a patient who has very low vitamin D, the doctors prescribe 50,000 IU of D2. Now, D2 is collected from plant-based. It's a plant-based supplement. D3 is an animal-based supplement, meaning they're taking basically the pigs of the skin and the skin of the pigs who sit in the sun and derive vitamin D from that. But D3, the animal-based, is actually much more efficient and effective in elevating vitamin D levels than D2. So I don't know why the prescription dose is D2 and the over-the-counter is D3. And I have patients who have been years taking 50,000 IU D2 a week, I think it is, a week, and they don't get better. And I'll say, well, why don't you ask your doctor if you could take the 5,000 IU sublingual, which I really think is better, sublingual D3, which you can get for $10 on Amazon, and try that. I mean, maybe a better source, and you might have ideas on that. But that actually helps them get their levels back up. The D3, it's just a little more efficient in the body.
Yep, I agree 100%. Somewhere between 2,000 IUs and 5,000 IUs is what's needed to start to shift people's D levels. Anything below 2,000 is really quite low, and you're not going to shift it, especially if you're not getting in the sun and eating some foods that we talked about. And sunlight's obviously, beneficial for people. Sunlight's
the number one source of vitamin D. We didn't, I'm glad you mentioned that because I didn't, and that ideally, if you could stand naked in the sun for 15 minutes at noon, you might have enough vitamin D. Who does that?
That's the funnest version of therapy I've ever heard on this podcast. If you do that, I'll meet you. Let me know.
Okay.
Let's shift to physical exercise and physical activity, since we're both in the realm of physical medicine and rehabilitation. So important for people with pain, osteoporosis, osteopenia. Tell us what your recommendations are for exercise and physical activity.
Well, the most important exercise is weight-bearing exercise, as you know. And I'm an advocate, and I'll tell people, I know, there's a strong push to aerobics or aquatic therapy, and all that's fun and good, and it's great exercise, but it's probably not going to build the bone that you need. So if you have a special need, like osteoporosis or osteopenia, you need weight-bearing. You need to lift weights. And honestly, I do a lot of impact. I'll have people, instead of walking, or a lot of hikers around here, I live in the mountains, march a little. Give yourself some weight bearing. One of the favorite exercises I give my patients is actually bouncing on a big therapy ball. They love it. And they usually buy one, and they'll sit in front of the TV and they'll kind of bounce and get that. I teach them about posture, of course, so they're not bouncing on a spine that's all kind of forward and, out of whack. But I teach them the importance of bone impact. And that impact will stimulate the bone cells to just regenerate. So the biggest piece of research that I love to share, though, is the vibration platform. There's been a whole lot of work. There's been 2 articles that I really love. One on jumping that was done in China. And, of course, the Asian population, as I mentioned, have a high risk of osteoporosis, osteopenia. So they found that jumping really benefited the hip especially. So jumping, a lot of my patients have osteoarthritis, which is different, and, as you know, but maybe the audience doesn't. So if you have osteoarthritis, maybe jumping might not be a great choice for you. But vibration has found between 25 and 35 hertz of vibration 10 minutes a day has been shown to promote bone density. So I have a vibration platform in my office. I have everybody try it. who has osteopenia or osteoporosis. And then there's a home unit that I've partnered with a company that I think they put out a great product, and I use their product every day. I don't have osteopenia, but I feel like it's a good way to prevent it and to still help my bones. I'm 60 years old, so I want to maintain my bone health. And I have my husband doing it, of course, because he has osteopenia, and I'm doing it. It's also a good tool to just work out on. I do planks on it for my upper body strength, and it really just accentuates the benefit to your muscle. Do you have any experience with the vibration platforms at all?
I've read the research on them. The research on them are fascinating. For those who may not know what you're talking about, explain what the vibration platform is.
Well, it varies. The one in the clinic is like, I should have put a picture up, but it's basically a big disc that vibrates, and it has to have the side-to-side vibration, because that's exactly what the research has shown helps, versus just a kind of a static. It has to be this side-to-side vibration, and it goes at a rate of like 25 to 35 hertz is basically the rate that we're talking about. And you stand on it. And if you stand completely straight, you'll almost feel your bones vibrating. You could do squats on it, which would be good for your muscle, but not as stimulating to the bone, because you're not getting that kind of impact that we want. The home unit doesn't have a handle to hang onto, or a control panel in front of it like the one in my clinic. It's just basically a flat platform that you place next to your dresser, and it has a remote that's connected by Bluetooth, and you just turn it on and you elevate it to the intensity, the hertz that you want, and you stand there. And I check my phone. It's a little shaky when I check my phone, but I usually do that 10 minutes a day. And again, like I said, I also add some squats or add some planks on it in order to just keep my body strong.
Yeah. And that the idea of the impact that you're mentioning, it's almost the opposite of what people would think. Well, if my bones are becoming more fragile, so to speak, which is not necessarily exactly what's happening, but people feel like, well, I should not do impact because it wouldn't be good for me. But it's it's a paradox. It's the exact opposite.
It is.
That
and that's why education is so important. And there's also been research as to educating people with osteoporosis. Does this work? And that it does work, because it is a paradox. It isn't instinctual. It isn't something that you're going to naturally do. If you've been told that your bones are fragile, you're like, oh, I need to protect them. But no, you really need to exercise them, stimulate them, make them grow a little bit more in a careful, controlled way. And that's why the education, again, is important. It has to be done with good posture. We don't want to stir up more knee pain or back pain or any of that. So we want to make sure that people are doing it with correct form. Yeah. And this is also part of my program. I do tend to have people who don't want to exercise. They're not exercisers. So standing on a platform is an easy way for them. They're more likely to buy that platform than to maybe go for a hike, or do like some of the other exercises. I try to make the exercises I give geared towards the people who don't really exercise too much. If they want to exercise, I give them more. But I'll give them some easy TheraBand exercises that they can do sitting. I will teach them how to do a chair squat, so that every time they get out of the dinner table, or they leave the table, they get up and they go back down and do one squat. Just do one squat, so up and down. You get up from the couch to go to the bathroom, get up from the couch, go down to the couch, stand up again. You've done a squat. So I try to incorporate everything in their daily activities. One of the things that they laugh about and they like is that I have them using their electric toothbrush. Most everybody has an electric toothbrush. I said, that's 2 minutes. I want you to bounce while you're doing the 2 minutes, or I want you to do squats while you're doing the 2 minutes. You're already standing there doing nothing, so incorporate it. Or you're standing at the Walmart line and you've got to wait in line. You work on your balance. So I teach people, just a tandem stance. You can bounce while you're in the Walmart line. You can just balance on one leg, let go of the cart for a minute, see how long you can go. Let's improve your balance. So I try to make sure that the exercises are simple. They're very simple. Anybody can do them, and they should hopefully make a difference if you incorporate them in daily activities.
Yeah, I love that. So you're interspersing little bouts of activity throughout the day, which is important. And as I listen to you and you're talking about this, what you're really doing with all these techniques, whether it's the vibration board, whether it's the impact exercise, little bouts of exercise. You're helping build someone's physical resilience, but you're also helping them feel more confident about their physical ability to function in daily life, which is so important for people who've fallen, right?
Right. Exactly. They do. And they come back to me. Like, my program is only 4 weeks. It's a group session once a week for 4 weeks. It's very structured. They end up with a notebook with all the exercises that they need. And they come back, and they usually, some of them have shared their bone density, which nobody's gotten worse. Some have gotten a little bit better. Some don't do the exercises and admit it. So that's kind of the nature of our practice, I think, sometimes. But most of the feedback's been so positive that many of the primary care doctors in my area have just started referring to this program.
So you skipped a rock over your program. I want to hear some more detail about the program. So other practitioners, of course, are going to be interested in this, because we talk about building programs a lot on this podcast. So you have a program specifically for osteoporosis, osteopenia, and then tell us what else is involved in it.
Well, the program itself consists of one-on-one evaluation and then 4 consecutive group sessions. The groups are usually between 3 and 5 people. I have spoken at length to insurance companies and Medicare. Medicare, we know we bill it so now I'm talking to the practitioners. Medicare is billed as a group rate, usually 100% covered for the Medicare recipient. If they have a replacement policy, I've talked to Humana, United. They're all on board as long as there's no more than 4 people. So you can do this program and bill the insurance. Many times, if you have, it's reimbursable, because a lot of practitioners shy away from these programs because they're like, well, how am I going to get paid? Well, you are going to get paid. I have had a physical therapist in my company do this program and love it. She worked at a life care center, and so she had lots of potential customers, and she loved it. I have another OT doing it right now, and I'm hoping that we catch on a little bit more with my company. I do work for Benchmark Physical Therapy, which is also known by Dreher. Dreher is part of the upstream group, so it's a huge, probably number 3 rehab provider in the country. So we're hoping to provide this in more sites. So, and maybe even I would even package it for sale if anybody's interested. I just believe in this program, and I think we've seen it work, and it's backed up by all current research.
Yeah, I mean, the evidence is there.
Evidence is there. Yeah. And the hardest thing is getting the doctors to actually diagnose this or even care that much about osteopenia. And I think that's this country, and less so, like I said, in Europe. But this is an important problem. This is, contributing to falls. It's contributing to fractures. So we need to keep that in mind.
And is that because in the beginning, osteopenia is kind of symptomless, so to speak, meaning?
Right. It's a silent disease.
It's a silent disease, yeah.
It's silent until you fracture. Fracture is the number 1 symptom. The other symptom is back pain that doesn't go away. And that's the sign of a fracture. So you could have a vertebral fracture. If you're bad enough, you could fracture a rib or your spine just rolling over in bed. And I've had that happen with people. They could bend over to pull their pants up and they fracture. So a severe case is going to be that easy to fracture. And so if you have pain, constant pain that isn't relieved with heat or cold or exercise or stretching, you might want to get an X-ray. That's all, I guess I would say.
And what type of physicians are referring to your program? Are they primary care doctors? Are they
primary care?
Mostly primary care.
And rheumatology. I'm expanding. We just got our new rheumatologist in our town. Like I said, a small town. It's thrilling to me to have a rheumatologist, and he loves the program. So yes, he would. I think endocrinology would be a source to tap into if you have an endocrinologist around too. But definitely your PCPs. I've had tremendous support from them, and the nurse practitioners and physician assistants. They don't know what to do with these people. They get these bone density back, and all they know to do is to provide medication. So I've had to educate them and say, no, this is the research. I've handed my best recommendation is to take a piece of the newest research showing that diet and exercise improves osteoporosis. And I don't know if I shared that with you or not, but I can send it. And we can link it to this podcast. But take that, go to your PCP and say, look, can we try this before we try medication? The medication side effects are not very good, and most people don't really want to take them.
Can you tell us about some of the side effects that people are unaware of?
Well, the most serious one, which depending on what you're reading is prevalent or not prevalent, is osteonecrosis of the jaw, which is one of the side effects of a biphosphonate that can occur. And it'll say in all the literature that the patient gets that could be a side effect. The other most prevalent side effect is gastric distress. Obviously, people don't know that with a biphosphonate, they have to take it first thing in the morning. They have to stay upright, not bend over, not eat, not have your cup of coffee for 1 hour, and then you have to eat. So in order for you not to have the gastric upset. So the biphosphonates or your Fosamax and the more common ones, that's the first line of defense typically that the PCPs will recommend. The Prolia and Forteo are injectables that are usually reserved for more serious cases or people who can't tolerate the biphosphonates. But wouldn't you want to try diet and exercise first? Maybe hormone therapy. I mean, that to me sounds a little safer than going to these strong drugs.
I mean, the idea of having osteonecrosis of the jaw is terrifying for me.
Is
that as like a similar outcome to osteonecrosis of the hip?
I don't really know what the outcome is, but I did talk to my dentist who has seen it. And it was due to a biphosphonate, and they were freaked out. They're like, I'm never going to take on it. So from the dentist to be freaked out by it, probably means it's not easy to treat.
Yeah, I mean, you lose function of your jaw, which has obviously speaking.
I mean, you'd have to have a graft of some kind, right? Or some surgery to strengthen your jaw, or you couldn't eat. I mean, I don't know.
Yeah, so, and then most jaw things are extremely painful. Most jaw conditions are extremely painful.
Yeah, that's what I think.
Yeah, jaw and face. Is there a name of your program?
Actually, I don't really have a name. It's called the osteoporosis. It's referred, like the doctors just refer it to the osteoporosis program or the osteo program, but I guess I should come up with a name.
We're going to work on a name for you for that, Pam. Even if we have to call it Pam's osteoporosis and
program.
But we're going to create a really good name so we can help this program go as far as possible to help.
Oh, that'd be great. I would love that.
So people are going to want to learn more about, of course, your program and all the great things that you're doing. How can people reach out to you and learn more?
My email is probably the best. It's ptutten@benchmarkpt.com for physical therapy. Our website to find a location and maybe ask for the program, and then we can kind of coordinate it, would be the benchmarkpt.com. That will lead you to the whole Upstream family. We have clinics all over the country, so I can't say. I don't think we have any in California or Florida, but I think we've even expanded into New York, into your territory a little bit. So I'm not sure what it's called, but.
And yours is, and what town in Georgia are you in?
I'm in Ellijay, Georgia, which is about an hour and 20 minutes north of Atlanta.
Okay, so people can obviously go to benchmarkpt.com, and if they want to look for you specifically, obviously in Ellijay, Georgia, they can search.
Ellijay, yep, Ellijay.
Yeah, Ellijay, Georgia, Benchmark PT. You can find Pam Tutten, of course, all her information on there. This is the first episode we've done on osteoporosis and osteopenia. It's a really important topic for both men and women with regard to living a healthier life. Definitely looking at lifestyle regarding diet and food, physical activity, all things that we speak about in this podcast, Pam. So I'm so happy that you were here and you can share your knowledge with us.
Thank you. Thank you.
At the end of every episode, I may ask you to share this with your friends and family. So make sure you grab this link and share it with your friends and family on Facebook, LinkedIn, Twitter. If you're on your cell phone, make sure you click the little share button. You can, of course, share that through iTunes and text it to your friend or your family members so they can read all about it. Once again, I want to thank Pam from Benchmark Physical Therapy for being on the Healing Pain Podcast, and we'll see you next week.
Thank you.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.